Well, we're going to travel to the other side of the U.S. To Ken Binmoeller in San Francisco. And we'll be moderating from here.
Oh, great news. So we are the moderators?
We are the moderators.
Nice couple of moderators.
Ken, are you with us? Hi there.
Good morning. Can you hear me?
Yes.
Ciao, Ken.
Perfect. Good morning from the opposite side of the U.S., apparently, I guess. And it's, I guess it's almost noon now, San Francisco time. I've already started the therapeutic curved linear array echoendoscope. And we're starting with the endoscopic exam, of course. It's called endoscopic ultrasound. And you can see here the stomach. And a few words to the history, since you may not have it. 47-year-old male, heavy alcohol use. He enjoys vodka. He was admitted yesterday with fever and abdominal pain. He had a CT scan done that showed a 4-centimeter cystic lesion suspicious for an abscess in the body of the pancreas with changes of acute pancreatitis. He has no prior history of pancreatitis or pancreatic fluid collection, so this is his first presentation. My goal today is to look at this 4-centimeter lesion and determine if this might be the source of his fever. He has a white count of 18,000, but he's not septic at this stage. All right, so now you can see on the endoscopy that there's a mosaic pattern to the posterior wall. So that already indicates that there's some inflammation going on in the retroperitoneum. Now, we don't really see a bulge, but maybe some extrinsic compression. So let's just switch now to the ultrasound view immediately, and let's take a look. So now go to the ultrasound. Switch to the ultrasound, please. Just need a quick moment so we can switch to the ultrasound view for you.
No problem. And so what will you be immediately looking for?
There we go. Now you should have the ultrasound view. Now what you'll notice is a lot of inflammation here. There's thickening of the gastric wall. That's not surprising. There are a lot of lymph nodes here. There's a lot of inflammation going on. And I'm just looking to see whether I can identify a fluid collection. And here it's starting to come into view. So here's something. Here it is. All right. So you can see there's a lot of inflammation around it. And I estimate that it measures 4 centimeters. So let's measure it. So we have 4 centimeters on the CT scan.
So Ken, it looks like there is a capsule. There is a wall.
4 centimeters, look at that. I'm having a little difficulty understanding you. I apologize. Can you repeat that?
So are you, what do you think of the wall that is there? It looks quite thick.
Yes. It is thick. It is thick. So it is already a mature collection. And you can see there's a little bit of debris at the bottom. Some necroses probably here. It layers out. But I think this would be a good candidate. So good candidate means that there's abutment against the gastric wall. And you can see that here. Here's the gastric wall. We also we see that there's probably adherence to the gastric wall as well. So this would equal.
Well, we're going to travel to the other side of the U.S. To Ken Binmoeller in San Francisco. And we'll be moderating from here.
Oh, great news. So we are the moderators?
We are the moderators.
Nice couple of moderators.
Ken, are you with us? Hi there.
Good morning. Can you hear me?
Yes.
Ciao, Ken.
Perfect. Good morning from the opposite side of the U.S., apparently, I guess. And it's, I guess it's almost noon now, San Francisco time. I've already started the therapeutic curved linear array echoendoscope. And we're starting with the endoscopic exam, of course. It's called endoscopic ultrasound. And you can see here the stomach, and a few words to the history, since you may not have it. 47-year-old male, heavy alcohol use. He enjoys vodka. He was admitted yesterday with fever and abdominal pain. He had a CT scan done that showed a 4-centimeter cystic lesion suspicious for an abscess in the body of the pancreas with changes of acute pancreatitis. He has no prior history of pancreatitis or pancreatic fluid collection, so this is his first presentation. My goal today is to look at this 4-centimeter lesion and determine if this might be the source of his fever. He has a white count of 18,000, but he's not septic at this stage. All right, so now you can see on the endoscopy that there's a mosaic pattern to the posterior wall. So that already indicates that there's some inflammation going on in the retroperitoneum. Now, we don't really see a bulge, but maybe some extrinsic compression. So let's just switch now to the ultrasound view immediately, and let's take a look. So now go to the ultrasound. Switch to the ultrasound, please. Just need a quick moment so we can switch to the ultrasound view for you.
No problem. And so what will you be immediately looking
There we
for?
go. Now you should have the ultrasound view. Now what you'll
it.
notice, there's a lot of inflammation here. There's thickening of the gastric wall. That's not surprising. There are a lot of lymph nodes here. There's a lot of inflammation going on. And I'm just looking to see whether I can identify a fluid collection. And here it's starting to come into view. So here's something. Here it is. All right. So you can see there's a lot of inflammation around it. And I estimate that it measures 4 centimeters. So let's measure it. So we have 4 centimeters on the CT scan.
So Ken, it looks like there is a capsule. There is a wall.
4 centimeters. Look at that. I'm having a little difficulty understanding you. I apologize. Can you repeat that?
So are you, what do you think of the wall that is there? It looks quite thick.
Yes. It is thick. It is thick. So it is already a mature collection. And you can see there's a little bit of debris at the bottom. Some necroses probably here. It layers out. But I think this would be a good candidate. So good candidate means that there's abutment against the gastric wall. And you can see that here. Here's the gastric wall. We also we see that there's probably adherence to the gastric wall as well. So this would equally be a candidate for placement of plastic stents if you choose to, because there's good adherence here. And so you can use the standard Seldinger technique. Now in our practice, we've transferred over to using LAMS for all of these fluid collections. Part of the reason for that is just it's so much faster, easier, and it really gives us the ability to use the LAMS as a port to enter into the cavity inspected. And especially if we think this is infected, and I don't know, we'll see, then it's important that you get good drainage afterwards. So in terms of the size of the LAMS, you could use a 10 or a 15. I'm just going to go ahead and use a 15 here because my experience has been, even though you don't need a larger LAMS, if there's some necroses form, it's going to be easier for that necroses to drain through a larger diameter. So I just always use a 15 now. I don't use a 10. Now you do have to you have to modify your technique a little bit and be more careful if you use a larger LAMS for a smaller collection like this. So I'll show you that. But firstly, hopefully you can see me inserting the delivery sheath, which has a hydrophilic coating. So all you need to do is wetten that coating and it allows it to slide very This next part,
the diameters you were, the numbers you were referring to were the diameter. I believe now there's also 2 saddle lengths available, a 10 and a 15. How do you choose which one to?
That's correct. So, generally, I rarely use the 15 saddle length because if it's already that separate from the wall, I just have some other concerns that need to be addressed, but usually the 10 millimeter saddle length is sufficient. Now, in this case, you can certainly measure out the distance here if you're not sure. So you'll see this is only 4 millimeters. And the other thing I should actually emphasize is that you always switch on your Doppler. You should make that sort of a routine habit to always check the wall for interposing. And when you do that, you need to release your transducer so you're not compressing the wall with your transducer. So with the up-down wheel, just sort of release that pressure against the wall to see if there are any interposed vessels and just scan around. So remember, when the flange opens up, and this is going to open up to a diameter of almost 3 centimeters, right? Then you don't want to have that flange close to a vessel if possible. All right, so I'm going to turn the Doppler off now, and we will proceed to advance the sheath out. And what's very important is that you not push this sheath against resistance, because then you can start to partially deploy. And when you're angulated, that's when you may get more resistance. So now you can see the sheath coming out. It's very echogenic. It's right up here. And Courtney, my nurse, just told me that I'm hot. I like that. So that means cautery was just applied. She's going to disconnect that immediately after I'm in. But I'm in a good position now. I can see the sheath linear. And if you're beginning, then it's always smart to just measure out the distance between the tip of your sheath here and the opposite wall. See, now that's 2.4 centimeters. So you just want to have some estimate of how far in your stroke length is going to be. All right, so I think we're ready to go. And so what I'm doing now is I'm just the sheath forward, like an FNA needle, and I'm just advancing that sheath forward, and I'm stepping on pure cutting current to go in. And I'm in. Now, once you're in, you get some bubbles from the diathermy. Courtney just disconnected immediately so that I don't end up burning through the opposite wall. You don't want to accidentally do that. And I'm just going to press this all the way against the opposite wall now, but I don't want to start displacing the cyst away from the gastric wall. If it's not fully adherent, that can occur. Now I am going to lock the sheath. All right, and now I'm going to take off the safety here. That's the yellow safety. There's a gray hub.
Do you have a rule of thumb to ensure that you have enough catheter in, or do you adjust as you go along?
I'm going to adjust as I'm deploying this. Just do it slowly, that's all. Just make sure you do it slowly. Slowly,
pushing
slowly.
The catheter forward a little.
Coming now, right? There it is. Now it's fully deployed. It's a nice big disc, right? Now you want to snug this up against the wall of the cyst like this, like that. So I won't deny this is a relatively big LAMS for for the size of the cyst. But as I said, I want to get excellent drainage afterwards. It's really about the risk of the LAMS getting occluded with some debris and necroses or even food afterwards. All right, so now I'm in great position, and I'm going to deploy the proximal flange inside the working channel of the echoendoscope. So now I'm locking again, right, so that the sheath doesn't accidentally jump forward or anything like that. And now I'm pulling back the gray hub. I heard an audible click, right? So that means that the distal flange is fully deployed. Now I'm just deploying the proximal flange, and it's fully deployed now. Now I'm going to switch to the endoscopic view. So let's get the endoscopic view up. And all I do now is under endoscopic guidance, give some gas, it is CO2, and push the proximal flange out of the working channel. And there it comes. And it is now deployed. See? Now that's fluid. And it doesn't actually look purulent. So, you know, maybe this isn't the source of his fever. You know, we maybe have to check further. But we'll definitely get some of this fluid and send it gram stain and culture sensitivity. But I have to say, I'm not that impressed with the fluid. It's not looking very purulent at all. So now the next point is when you pull this out, this is the cable. You've already deployed the stent, but at the tip, you have that bougie-shaped ceramic tip. And that thing will, you know, barely fit through the saddle lumen. So you need to pull back slowly. You may even see the micro wires that run along the side and converge at the very tip of the ceramic bougie tip. All right, so I'm pulling this out, and now I'm going to dilate the tract, and I'm going to use a CRE balloon, and I'm going to dilate up to the diameter of the lambs, which is 15. So the CRE balloon is going in. Now you could do this through a gastroscope, of course, but I find that great position. I have great visualization. I have an elevator that I could use. So I find it easiest just to use the Echoendoscope to do this. Now, if you ever have difficulty, you can always advance the wire out first, but otherwise I'll just target that lumen. You want to make sure, of course, that you're not going in the interstices there, but here it goes very easily in, and you don't want to push too far, especially with a smaller lesion like the gallbladder. You want to be careful there, a non-adherent structure, that you don't push the gallbladder off of the lambs, the distal flange. So I'm in far enough. Start to dilate up. We'll go up to 12 first, right? It's 12 to 15, so we'll go up in stages. And the nurse would just tell me, and now I can push it out like this. Make sure that it's in the axis, right? And you can see it inflating, right? And so I'm at 12. There's a little fight, so we just wait till that fight's gone. All right, now go up to the next level. Now, when you dilate up to 15, it's not really going to be 15. And in those cases where I really need to get optimal drainage, I might even go a little higher. So I'll pick a 15 to 18, but this is fine for now. All right, and now go to 15. So that'll be the full. So it's all under direct visualization, good position. And when it's up to 15, I deflate, go down, and then we're gonna look again and pull out very slowly. Everything can always stay, this is like ERCP, right? You see in the axis of the bile duct. All of these skills are transferable. So now I'm coming out, and now you can start to see inside of this. But now I'm going to switch out quickly for a gastroscope. All right, so there's our...
Ken, can you hear me?
Yeah, I can hear you, yes.
Hey, Ken, this is Ale. So we are running a little bit late, so I don't want to give you pressure, but can you tell us if you have another case?
I do have another case. Let me just, give me 2 seconds to look in. Yeah, I've got a case of, I've had a lot of cases this morning, Ali, but this one is a patient with multiple polyps, large ones. And as soon as I just look in for one moment and suck out a little bit, I'm going to run quickly over to the other room. And
can you tell us what will be next case?
Pardon me?
What will be the next case?
Yes, this is a patient. He is 78, and he has multiple polyps found on screening colonoscopy in the ascending colon and the sigmoid colon.
So I can assume everything will be underwater.
Oh, yes, of course. And
Good.
so let's put CO2 on, please. So we only use CO2 now in our unit. Okay, so I'm just going to show you how you inside like this. And we always go in and inspect the inside of the cyst just to make sure. And it's unlikely, but you can be fooled. It could be a neoplastic cyst, and it looks good. And it's because I want to irrigate with some water. Where's the water pedal? Here it is. So you can see here with the water, you don't want to infuse gas too aggressively in here. So you can do underwater cystoscopy and just to whet your appetite for the next case. But everything looks good. So I'm going to pull out now. Everything looks good. I can see that we're not seeing any pus, minimal debris. So, and I'm going to go to the other room, and I'll see you in a couple minutes again.
Okay, we have an infomercial to show, and we will see in a couple of minutes. So Thomas, if we can send live the next infomercial, please.
This patient had undergone both percutaneous drainage and LAMS drainage for a LAN and is readmitted with sepsis. The LAMS is occluded with necroses. There's pus draining. We insert the endorotor through the working channel. You can see the 4mm window at the tip. For necrosectomy, we use high cutter speed, high flow rate, and high suction. This is a all-in-one device. We can suck, cut, and clear without having to remove the endorotor from the cavity. This is called powered debridement, which means there is really very little effort on the part of the endoscopist. We are basically dipping the tip of the endorotor into the necroses and very gently rotating the outer catheter. This rotates the window to the desired orientation. We try to keep the tip at the edge of the necroses, essentially working the tip like a wood chipper. So we are gently swinging back and forth, righting the edge of the necroses. Here you can see nicely illustrated how rotating the outer cannula rotates the window at the tip. You can dig the tip more deeply into the necroses. What we look for is the necroses spinning around, indicating that it is being suctioned in. Here you can see a large amount of pus after we have opened up a pocket of necroses. So we have nearly completely evacuated the necroses. There's a small amount of residual, and here you see the percutaneous drains in place.
So Marita, I have a question. I was fascinated by this Interscope procedure with a lot of debris in the pseudocystem speeding up. What is your experience with this Interscope device?
Yeah, so I think it works very effectively. It does take some time. It's a little bit tedious because you sort of are keeping the scope in place as opposed to other necrosectomy techniques where you have to go in, gather the necrosis, and then pull the scope out in order to actually debride and remove tissue. And I think what happens sometimes with other devices is that you can get a good amount of tissue, but by the time it's so attached due to the consistency of the material that by the time you actually come out of the cavity, you have very little material. So the time saved in actually being able to stay in place and physically debride that tissue in place, and the suction capability is extremly strong, and the ability to irrigate.
So you suggest to have a therapeutic scope also to improve suction? What you do?
Yeah, so the current catheter requires a therapeutic channel scope. You can use either a single channel or a double channel. The double channel would allow you to have a little bit better suction, but the suction is actually within the catheter itself. So it's really sucking up the material that gets sort of cut.
So the concept is a blade, a rotating blade. So whatever is the contents, it can be used, no?
Yes, yeah. The other indication for the device is for resection of mucosal neoplastic lesions. So it's the same.
Especially
concept.
fibrotic, no?
Very fibrotic is a great indication. So it really can cut the material and immediately capture it so you don't lose any of the pathology and you're able to both resect and
Good point.
evaluate. Yeah.
So in general, it requires a lot of skill. You have a learning curve for using this Interscope device. Can you tell us?
No, I don't really think too much of a learning curve. It's a lot of painting, similar to if you're used
So you
to
need to
doing
be patient.
APC.
Patient.
Patience, yes.
Take your time,
Patience.
relax it there, and let the device making its work, no?
Yes, exactly.
Okay, good. So I don't know if Ken is ready. I don't see Ken. No, probably Ken is on. Ken, you on?
Yes. Yes,
You
good.
doing
Can you hear me?
colonoscopy? Yeah, you doing colonoscopy already? Okay, good, good.
Yeah, so I've just inserted the adult colonoscope HD with near focus capability. And I'm using the water exchange method. It's actually saline exchange because we're using saline. And the gas is turned off. So I'm doing the whole colonoscopy underwater now. And the key when you're doing this underwater, you want to use the infusion of water, which I control with the foot pedal, to distend the lumen just enough so that you can see where to go. That's all. So you are trying to avoid over distension. You can see already there's a polyp here. This looks like more of a semi-pedunculated one. So you know what? Just because of time, I can show you how we do that. Give me a 20 millimeter snare. So normally I'll take all of these out on my way out. But because of time, I don't know how much time I have. I'll take this one out.
Ken, this will be underwater single piece cold?
I'm sorry?
This will be underwater single piece cold resection?
Cold. I don't want to do cold. The reason
you don't like cold? It looks like a small spot.
That are maybe 5 millimeters or so. 20 would be fine. I think 20 will work, or 25 maybe. Let's see. Because there's actually 2 lobulations. Let's take the near focus off here. Let's see if the 20 works. Even a smaller snare will sometimes get the entire lesion on block. In this case, it's also semi-pedunculated, right? But it contracts the lumen. If it contracts, and you can float the lesion up into the snare. So you have it at 6 o'clock, first of all, good position. And let's open up the snare now. The other thing is, it looks like this may have even bled in the past, right? So looks like the 20 is a good size. So the idea is under vision like this, and I'm going to have the assistant just hold this a little clockwise. And now I'll go back into the near focus. See, the near focus lets me see. Now the key is to go do to and fro like this. That helps displace the lesion higher up into the snare, fully into the snare. Plus, you can see where the margins are very nicely. So there are 2 maneuvers. One is to and fro, and the other is torque and crimp. So torquing is this, back and forth, torquing. So both of those, and the final maneuver is gentle suction. All right. So
and we don't need any injection, no?
The suction is, with water suction, it's a very gentle, gradual suction in contrast to gas where it just reds out on you, right? So slowly close, please. Okay. And once it's closed, I give it the water to look and pull it away and see if I got the whole lesion. And you see it tense away very nicely. And you don't have to worry. You're not going to capture the muscularis propria because it stays round on the outside. It doesn't follow the involutions of the mucosa and submucosa. So now we're ready. Now, because there are probably some vessels in here, and because this is not a large surface area, I'm going to use coagulation current for this. And I'm telling Courtney, my nurse, not to just transect this right through right away. A very slow transection. And we have the heat sink effect as well, which is transferring the thermal cautery to the water. right? So it's minimizing damage both to the specimen and the wall. All right, so now coag, it turns white, right? And now it's through and there's no bleeding. Then I use the tip of the snare to kind of move this around like this. Take the near focus off because I'm a distance, and then put the near focus on to look more closely. And with what? Take it out. And I can look at the margins and see if they look clean. They look fine. So you could put a clip on here and close it if you want. This is in the SM2 layer. This is the second layer of the submucosa, and you're well above the muscle. So, you know, the layer of resection when you do underwater is different from conventional saline assist or injection assist EMR. All right, now let me just continue now.
So
Okay,
the water has basically allowed you to not have to do any injection. It's creating the same effect, correct?
That's right. But you know, everyone emphasizes the submucosal injection. Now, I won't deny that I have always had an issue with the theoretical possibility of tumor seeding, of dysplastic cells when you inject through a lesion. You know, I'm cognizant of that when I do FNA as well. But it's less about the submucosal injection for me. It's about the en bloc resection. I want to get these lesions out en bloc. So I use a snare size that will allow me to get it out en bloc. And that's the rationale for going underwater for me, because the lesion contracts and that allows me to capture a larger surface area. All right, now
Daniel,
as
we
I
have
go-
time for one question. We have time for last question from Amrita.
Yeah, so you've done have done a lot of work underwater, whether it be polypectomy, POEMs. Do you have to change your settings? Do you have special settings for underwater work, or are they the same settings for a standard
Good point.
polypectomy?
They are not.
You should
have
show
to
your
use-
generator.
Absolutely have to use different settings when you're underwater. So, and underwater, I'm using usually pure cutting current. And, but when I want to coagulate vessels, I have to use force coag with high wattage. Yeah, so the settings are different.
Great.
And the other is saline. I use always saline. And by using saline, I get excellent thermal transmission, diathermic transmission, I should say. Any other question?
No, that's been a fantastic demonstration. Thanks for your time. Thanks for being patient and waiting for us.